is Vesa, pharmacist by trade, but I spent the last few years completing a PhD on how to appropriately dose antimicrobials in critically ill adult patients on ECMO. So what is ECMO? ECMO is often used in some ICUs. So some of the really big tertiary hospitals will have ECMO being used to provide supportive therapy to the sickest of patients in the ICU. So essentially what it does, it is an artificial lung. Sometimes it acts as an artificial heart as well. And it keeps the patient alive until you can reverse the underlying pathology. Whereas, sometimes it's infection, sometimes it's a lung transplant, waiting for a viable donor. There's a lot of reasons why we would put someone on ECMO, but often it is the sickest patients, and it only works if you have a way to reverse the underlying pathology. So in this case, we're talking about infections mostly, because we'll need to use antimicrobials to reverse the infection that's causing the lung or heart injury while this patient is kept alive on ECMO, because we can't stop ECMO without having the lungs and the heart working again. So as you can see in the bottom graph is extracted from the ELSO registry. It's an international registry that tracks the number of centres and the number of ECMO runs conducted around the world. And you can see since the H1N1 pandemic in 2009, the number of centres using ECMO and also the number of ECMO runs has dramatically increased. And actually COVID has actually promoted this as well. So you can see more and more centres are just bringing on the ECMO program. This is a very simplified circuit of the ECMO machine. So essentially what it does is it takes venous blood away from the body, so blue blood, and it will run through these really large bore cannulas through the blood pump, which in some cases where the patient needs cardiac support, that would actually be the cardiac output for the patient. And it will push the venous blood through this oxygenator where the blue blood becomes red blood in the diagram. And the oxygenated blood then goes through a heat exchanger, right temperature for the body, and then reintroduced as oxygenated blood into the patient. So therefore replacing the lung function for some of these very, very sick patients. So why do we need individualized dosing? Mainly because neonatal research, which was actually the group that mostly used ECMO with the congenital heart diseases, a lot of these babies that were put on ECMO, they noticed that the doses that you need to achieve the same clinical response was significantly different to patients not on ECMO. And then often larger doses of these drugs were often required. And this was similarly observed in the adult population. Locally here at the Prince Charles Hospital, one of the local intensivists always talks about how he saw the BIS monitor, the awareness monitor, jump the second the blood ran through the ECMO machine. And it made him think that some of the sedatives and analgesic drugs being used in these patients were actually being sucked into the circuit and therefore being removed from the patient's body. And therefore the amount available to the patient was actually a lot less. So the plasma concentration was less in these patients. So the hypothesis that we had was the PK of these drugs were being changed the second we introduced the ECMO circuit, similar to what Claire was talking about before with CRRT. But with ECMO, we believe that the drugs were actually being, because they weren't being actively removed by the extracorporeal circuit, we think they were just being stuck in the large PVC tubing or potentially the oxygenator. We weren't really sure where it was being stuck, but it was being stuck somewhere. And this was important to know because different ECMO circuits in different centres uses different materials. So we wanted to investigate this. And also we know that especially in the neonatal population where the little bodies were significantly smaller than the big ECMO circuit, when we start ECMO, we actually introduce a lot of priming fluids to the patient. So the fluids that were introduced to start ECMO was significantly larger than the patient's body when they're neonates. It's probably less so of an effect in the adult population, but we also think that this is important for the smaller patients we see in ICU. And lastly, we think that there were some changes in how the body is clearing the drug. whether or not it was being destroyed by the ECMO circuit, or whether or not it was just because these patients were so sick that their kidneys and the livers weren't functioning as well. And therefore, maybe we saw higher clearance or lower clearance in some of these patients. Either way, the group thought that, you know, we really needed to look at antimicrobial dosing in this patient group because we needed to individualize this particular patient group to achieve those PK/PD targets that we talked about earlier. Now, this is a more confusing, but a more realistic diagram of how the ECMO circuit runs. And in reality, these patients often have multi-organ failure. So it's never as simple as just needing the heart or the lung support. They often need renal replacement therapy as well. So it's a picture of, you know, drugs being little yellow circles being infused into the patient. We actually want the drug to be in the patient because that's where the infection is. However, when they run through the ECMO circuit or the RRT circuit, we lose a lot of these yellow molecules. So these drugs get stuck in the tubing, gets lost in the effluent, get stuck in the membrane oxygenator, and the amount of yellow circles in the patient is a lot less. Therefore, that's why we need to do these PK studies to investigate what is a dose-response relationship that we have here, especially in relation to antimicrobials, where the concentration available at the infective site is really, really important for patient outcomes. So before this research, clinicians, as Claire mentioned before, tended to err on the side of caution and just gave more drugs. Luckily, with anticoagulants, analgesics, and sedatives, we could titrate it to effects. There were bedside markers we can use to guide dosing there. But antimicrobial, unless you have TDM, you kind of give it a go and hope for the best and give a little more just in case. And this was before the research. So what we did was, it's very hard to recruit ECMO patients, as I learned during my PhD. So we actually needed to do a multimodal approach where we use some in vitro studies, ex vivo studies, and animal studies to see what drugs do we want to focus on. Is there some properties of these drugs that we want to really hone in on to see if those drugs were more likely to be affected by ECMO? And these informed our clinical PK study. So our clinical PK study, which I will be talking about a bit later, we realized from those previous studies that lipophilic drugs and drugs with high protein binding were actually more susceptible to being lost or being affected by the ECMO circuit. So we kind of really focused on antimicrobials with these properties, or at least with a range of these properties in our clinical PK studies, and we wanted to analyze these first. And this allowed us to have some suggested dosing regimens, allowed us to have some external validation, and we hope that once, you know, we have a lot of research, population PK research out there, we can have some larger scale clinical trials to help validate the dosing recommendations that can inform individualized dosing, or TDM, in these patients. So what we called our study was the ASAP ECMO study. It described the population PK of commonly used drugs in critically ill patients on ECMO, and secondary aim was to develop dosing strategies that would improve our likelihood of achieving these therapeutic exposures to optimize patient outcome. Focusing more on my PhD now, we had 6 study sites across 4 countries. As I mentioned before, it wasn't just antimicrobials that we recruited for, but my PhD focused on antimicrobials. So we looked at 14 commonly used antimicrobials. We had 1,182 blood samples analysed from 86 patients around the world, and they were all analysed here in Brisbane. Claire mentioned cefepime before, because I wanted to start here because it was one of the drugs that we didn't think would be affected by ECMO. It had a protein binding of 20% and it was not lipophilic. So it was a drug that we thought, oh yeah, we should look at that, but mainly have it as the, you know, not likely to be affected by ECMO. And it was exactly that. Our patients didn't have any ECMO variables that improved the prediction of the drug levels that we had. And the patients that we had also had a similar VD, but interestingly, a lower clearance compared to similar patients on cefepime in ICU, not on ECMO. And that actually led to our patients having a higher probability of achieving neurotoxic concentrations. So the graphs on the right was published within our group where it kind of shows how we can dose individualize for these patients. We could test individual variables like weight. So here you have 50 kilogram, 75 kilogram, 100 kilogram patients with different renal functions, 30, 65 and 120 mils per minute, with different dosing regimens down the bottom on the x-axis. The y-axis is the probability of target attainment. So the bottom line, so the bottom part of the grey line is of the grey area is a probability of toxic concentrations. And the top line of the grey area is a probability of efficacious concentrations. So essentially what we are trying to do is we're not trying to say this one dose will work for all ECMO patients. Individual variables as they change would change your risk of toxicity and your probability of efficacy. So depending on what your center's appetite for risk is, you can look at this graph and actually individualize how you want to dose these patients. So hopefully the papers that we've published here allows another step forward to understanding how ECMO dosing can work. Because the research out there at the moment to assist clinicians in dosing cefepime at the bedside is actually quite sparse. And secondly, Pepiricillin tazobactam was another drug we looked at. It was a drug that actually has slightly higher protein binding. So once again, we didn't think would be affected by ECMO. And this was exactly what we found. Again, ECMO variables didn't change the PK model. Didn't improve the predictions of the PK model, and the volume of distribution and the clearance that we had in our population compared to those published not on ECMO was very similar. However, luckily with Pepiricillin tazobactam, the therapeutic window is quite wide. So we actually had very low probabilities of achieving neurotoxic concentrations. And I think a few of the presenters actually talked about we often underdose Pepiricillin tazobactam. So as part of the paper we wrote for this one, we could test different renal functions, creatinine clearance 30, 100 and 160, and also patients with different weights. And we found that those were good predictors of what the drug concentrations would be. And we actually simulated different dosing infusions and also different frequencies as well. And we recommended that a 4-hour infusion was probably needed to achieve therapeutic levels in this group of patients. And this was actually supported by another centre overseas as well that also found that ECMO variables did not improve the PK model. However, they did find that it was a smaller volume of distribution in the central compartment, and also suggested that extended or continuous infusions are required in this group of patients. And lastly was ceftriaxone. So this was the drug that has 95% protein binding. And I was like, this is going to be the drug that's going to be interesting for my PhD. However, ECMO variables, once again, did not improve the PK model. And the final model we had a similar volume of distribution and a lower clearance. However, to build this model, we actually tested different creatinine clearances and also weights. But most importantly, we tested different levels of albumin, because we know high protein binding drugs are significantly affected by different levels of albumin, because we wanted to see the amount of free drug available in the patient. However, this was actually not found to change the doses that we need to treat this patient group in order to get the right PK/PD target. So overall, the preliminary findings from ASAP ECMO shows that ECMO flow rate, modality, brands haven't been shown to be significant predictors of antimicrobial PK. Physiological changes due to critical illness might actually play a far greater role. So I mentioned before that a lot of the patients that all of the drugs that we had showed either similar or slower clearances. Just remember that this group of patients is the sickest patients in ICU. So having a lower clearance in these patients isn't actually a surprise to us. And using drug physicochemical properties to predict ECMO-induced PK changes appears to be insufficient. So actually much more studies need to be done in this area. And actually every month or so, there's a new ECMO population PK paper coming out. And it's really exciting as the amount of information builds out there, we can actually use these to inform better dosing software and also help us to dose individualize antimicrobials in this group. So where to from here? There's still a lot of drugs that we need to analyze from ASAP ECMO. So we need to continue to churn through all the population PK analyses. And after that, we want to develop and establish dosing guidelines to help assist clinicians to individualize dosing at bedside. And lastly, as Jean mentioned before, larger, more prospective multinational trials to confirm the clinical impacts of these dosing software, dosing regimens are required to ensure that, we are doing right by the patients and what we are introducing works. So a few acknowledgements. I just presented work on behalf of all these people. So thank you.
Thank you, Vesa, for that excellent presentation on your work and obviously all the collaborations that you made during your PhD. It was fantastic to have you with us when you were doing it. We might actually